here. My name is Chase Napier with the Healthcare Authority. I'm the Community Transformation Manager. Just want to start by thanking you all for joining us for the webinar. As you can see, this is the Community Transformation Touch Base. What that means is the Community Transformation team here at the Healthcare Authority wants to set up some time to discuss the Accountable Community of Health Initiative. That's my primary role, is to lead the 9 ACHs across the state. And in the room here with me, I have a member of the team, the ACH team, Community Transformation team, Kayla Down, Community Transformation Specialist. And then on the road, who's actually just departing a Greater Columbia ACH meeting, is Lena Nashand, also Community Transformation Specialist. And then we have our Healthier Washington HCA consultant and partner, Jonathan Seib with Seib PPA. And he's going to help facilitate the call. I'll be handing this over to him in just a minute. On more of the technical side, this is all about answering questions and providing clarity. To do that, there's the questions function within the webinar format, so please document your questions. We might address those along the way. We more than likely will hold those until the end. We do have some time set aside to do that at the end because, again, lots of this format and agenda is actually Q&A that's already been identified. So that's the technical aspect. Just to remind everyone, this is our second monthly call. We want these to be meaningful and useful, so we're learning as we go. We welcome your feedback on what you liked, what you didn't like, what we could do to improve the format. And then also, if there are specific topics we didn't get to, just know that there's plenty of opportunity in the future to address questions and focus on different topics on the next call or even in between. So that's the idea here. And with that, I'm going to hand it over to Jonathan Seib, our consultant, and we'll get underway.
Thank you very much, Chase, and thanks for the opportunity to be here with you all. And for those that are listening, I want to start with reviewing briefly the overall intent of these webinars. As Chase suggested, the intent is they happen at least monthly, with the purpose first of providing basic information about ACHs for those to whom they are still new, and we certainly would encourage you to encourage those wanting to learn more about ACHs to join us. Secondly, to address in some detail either emerging issues or developments that are related to ACHs. Take questions from the audience to either answer during the webinar or to be answered at a later point. And finally, I think the notion that these webinars will provide the opportunity for announcements regarding ACHs, either from the Healthcare Authority or perhaps even individual ACH as we move forward. The hope is that the webinars will draw upon and help inform and update the ACH Frequently Asked Questions, or FAQ, which is available online and which the Healthcare Authority hopes to maintain as a key source of information about ACHs, or certainly at least as a basic starting point. Today's agenda, we'll have a start with some, again, brief but key background on ACHs and their development. We will then focus in more detail on the ACH progress report that was recently completed by the Center for Community Health and Evaluation. Provide an update on the role for ACHs under the proposed Medicaid waiver, which will still hopefully leave time for your questions, or at least some questions that we hope to get to on the call. So with that, we will start with Chase speaking at a high level, and I say Chase, I certainly would encourage others around the table from the Community Transformation team to weigh in as appropriate on some of these questions and discussions. But we're going to start having Chase speak to the high-level role of ACHs in Healthier Washington, and in particular, Chase, can you talk to us about where the idea for ACHs came from? What, in fact, are they intended to accomplish? Again, speaking to those for whom ACH is still a new concept.
Yeah, for sure. So the idea behind the Accountable Communities of Health, I guess we will start there. It's not entirely new. I mean, we know that health improvement is a priority in Washington State. It has been for a long time, and we also know that community coalitions and partnerships are a necessary component of that. But the ACH initiative, as we developed the State Healthcare Innovation Plan and even led by state legislation, really supported the notion of multi-sector partnerships that are local and a more formal recognition. So it's not to say that this is entirely new, but building on existing partnerships, building on existing community coalitions, and I would say formalizing that and enhancing that. The importance is being recognized through the Accountable Communities of Health, and we really are trying to support the relationships that either existed already or needed to be enhanced. And a lot of this is new partnerships too, or expanding partnerships where we might have different sectors that weren't discussing health issues and shared priorities within these settings in the communities. And so that's now happening, I think, in a way that it wasn't before. So that's a little bit of kind of where it came from. Again, we mentioned the State Healthcare Innovation Plan. The SIM test grant, of course, is something I think we'll talk a little bit more as we talk about the Healthcare Authority and why we have the Community Transformation Team and the support role we play. But under the SIM test grant, the importance of the Accountable Community of Health initiative is that health really is local, and it's really based on the idea that clinical community partners, government entities need to coordinate more effectively, and we need to have shared goals that support whole person health. So recognizing the importance of healthcare delivery, also recognizing the importance of the community and social supports, and all of the linkages between those two, that they're necessary to recognize and to coordinate across those environments. And so that's the idea with the 9 ACHs in the 9 regions we have, as we can see on the map on the screen here. So as we focus under SIM and Healthier Washington broadly, even beyond SIM, on better health, better care, and lower cost, as we focus on some of the delivery system transformation and the integration efforts of whole person care, the ACHs represent an incredible partnership in these communities across the state, where in fact we have many communities that are coming together in these regional ACHs. And we'll talk a little bit more, I think, about some of the work of the ACHs, but that's just a high level of why we think the local partnerships are so important and aligned with the state goals, but really what are the local priorities, local strategies, and local partnerships that are going to really drive this work forward.
So Chase, you mentioned, and it's frequently a phrase that's mentioned with regard to Healthier Washington and the ACHs, is this notion of whole person health. Can you talk a little bit about what that term means? As frequently as it is used, I think it's probably valuable that there be a common sense for what you're talking about when you say that.
Yeah, that's a good question. And sometimes we say whole person care, sometimes we say whole person health, and I really think that there are two meanings you could derive from those two different terms. And so, first, whole person care, thinking about the entire individual, and it relates to when we talk about integrating physical health and behavioral health, which is the mental health and chemical dependency issues, but also physical health. When we talk about whole person health beyond care, we're even going beyond that. We're thinking about those social determinants, the community aspects, the community environment and family environment. And there are many factors. In fact, most factors that influence health outcomes are even outside of the care setting. So that's why we like to refer to whole person health as, yes, it's critical to recognize the integration of care and the importance of care, but if we leave off the idea that this is health beyond care, we are really missing the big picture. So that's and the ACHs are the big picture. They are both aspects.
Thank you. That's very helpful and really appreciated. One other follow-up to this point. So you mentioned, in particular, the community groups, clinical groups, community groups, government groups, and the notion of ACHs as really a platform where they can work together, where they can collaborate. I know a question that I've heard that comes up is, well, weren't these groups already working together, and what's the role of the ACHs? What might ACHs do? What do you hope ACHs will do that wasn't already there?
Yeah, I mean, for sure there were partnerships and coordination already occurring. I mentioned kind of the formal recognition before, and I guess I'll mention that again, that the state has at times recognized formal local coalitions, but when we talk about the Healthier Washington initiative and the objectives that and incredible objectives when we think about how big the triple aim really is, we needed to really formalize the importance of those community partnerships and strengthen and support those. So it's not just recognizing, but it's also saying we're going to get behind this and we're going to empower the communities, and really what that means is empowering those partnerships, giving some credibility to those partnerships, and creating a different type of interaction between the state and community members and partnering organizations. So that's really the intent there. Is we're not pretending that none of this existed, but I'm just saying we're going to get behind it and support it, provide the SIM funding, provide some direction that we can, and then the resources. When Jonathan, you mentioned what do we want ACHs to do? Well, under SIM we have a bunch of different investment areas. We're not going to get into full detail today of what those are. I'm sure we'll have some time to talk about those later on, and there's plenty of information on our website. But when we talk about the practice transformation resources through the Health Connector model and the practice coaching, when we talk about the different payment models and using the example of fully integrated managed care, the ACH, if we can create a strong partnership that does have more of a formal recognition and a formal role with and formal partnership with the state, we can use that partnership in a meaningful way, and so not just empowering them to be a coalition that talks, but actually leveraging the different resources we have as a state agency and under SIM.
Thanks, Jason. I think in part what I'm hearing too is the notion that the ACHs want to take what may and was likely happening in communities in terms of these organizations that care about health in their community working together and making it intentional. That it not simply happen, if you will, as a matter of random connections, but really with some intent that it be systematically encouraged by the state, which is what the ACHs are to bring about. So in order for these ACHs to be successful, both individually and I guess as well, this notion that they are really intended to be partners with the state takes the engagement of state agencies. Can you talk a little bit about which state agencies are supporting the development of ACHs, and what does it mean to support them? How are they doing so?
Yeah, and I would say, because I don't want to leave out any of the important partnerships that occur beyond the key SIM test agencies that are primarily leading this charge. I just think it's important to recognize that community partners are supported by most agencies within the state, but focusing specifically on those SIM agencies and the partnerships that we have really built into the SIM test. Department of Health, Department of Social and Health Services, DSHS, and the Healthcare Authority, which is where the Community Transformation Team resides. So we're the three agencies primarily carrying out the SIM activities in partnership, but again, playing that lead role. And HCA is, again, housing the Community Transformation Team. We have a team here at the Healthcare Authority. I mentioned Lena and Kayla, but we also have members from DSHS and DOH that we meet with regularly. It's really, as much as we can have a coordinated approach, that's what we strive for. And so we have dedicated support that really focuses on the partnership. That's one aspect of it, being in the community, being part of the ACH development, being part of the ACH discussions, making the connections to other investments and other developments that are occurring, and also trying to bridge the gaps that might exist at the community level. As I said, the relationship across multiple agencies, even beyond the three that I mentioned. So one thing we can help is finding those gaps and trying to support the coordination at a regional and state level that might be happening at the local level, so that there's this parallel coordination effort. We also have, through our SIM test resources, we have technical assistance support that's dedicated to the ACHs. So the team here at the Healthcare Authority oversees that technical assistance work, and then also evaluation support, which provides some coaching with the evaluation and the formative approach of trying to do that rapid learning and adjustments along the way. So a good support team led by the Healthcare Authority, but close partnership with Department of Health, CHS, and that, I would say, is growing, that we're trying to make those connections to other agencies as well.
So talk a little bit about this notion of the agencies supporting the ACHs, and tell me, is that amount to the agency, in particular the Healthcare Authority, telling the ACHs what they can and can't do? How does that relationship work?
Yeah, it's a good question. I think it's a balance there. There's a fine line where it's because it's supposed to be community driven. We're trying to build on existing momentum and existing partnerships. We use the term flexibility all the time, but it's true that there's flexibility. So I would say the answer is yes, but more so in the terms of the principles. What are we trying to do, and what can we all agree on between the state partners and the community partners? And I think that's the aspects of balanced multi-sector representation, the value of community engagement, the need for clear structures and decision making if we're going to really take this seriously and create a meaningful structure at the regional level. How do we make sure we have the right people involved? How do we make sure we have the right structures and processes in place? And then how do we continue to learn and adjust? So we are setting some of those guardrails and some of those principles, making sure that we really do maintain those minimum standards. And we may talk about designation, which is an example of what some of those minimum standards are, while still giving some flexibility, knowing no one model or no two models are going to look the same in Washington, and that makes sense because of the different makeup of the different communities, the different partners that are required to be around the table, and just so many different factors that should be considered at the local level that wouldn't lend themselves to a tailored standard, a standard model statewide.
So I hear, I mean, it really is this notion of doing this on a statewide basis, but in a way that's sensitive to unique regional needs, and that challenge for the state to do that. You touched on, and this is actually a good transition to sort of some newer developments that we're going to talk about during the webinar, but I understand that since the last touch base call, all 9 of the ACHs have been designated. Again, going back to one of the questions that's in the FAQ that I think you can, in essence, update us on here now is, what does it mean for these organizations to be formally designated in ACH by the Healthcare Authority? Does this now somehow change their responsibility or authority? Can you give us the rundown on that development?
Yeah, and designation, you could have used any number of terms, and we use designation. It's really a milestone, and it's a significant milestone, but it really is just a milestone in development. It really recognizes that some of the aspects I mentioned, that we're expecting minimum standards around the multi-sector representation, community engagement activities, and we know we still have a lot of opportunity for improvement there, but at least having those community engagement plans in place and some representation around the table, the ability to convene and coordinate, the ability to administer the funding and oversight of the funding, regional planning. So with these partnerships and community members, and even multiple communities coming together to partner, planning efforts. We want to be able to see initial priorities and a kind of a roadmap of where are we going. So those were some of the standards within the designation requirements. So once ACHs could demonstrate that progress was made on those components, they had all of those elements in place, that's the milestone that we refer to as designation. Designation isn't the end result. It's not to say there won't be more development in each one of those categories and more improvement in each one of those categories. There will be and there should be as we learn more and as we mature, but that's at a high level what designation represents.
So a brief follow-up to that, does the fact that they've all been designated mean that they're all at the same stage of development operation? Are they supposed to be?
No, it doesn't. It doesn't mean that. It means they all have achieved the same benchmark, so a consistent threshold statewide. And but no, I mean, designation happened at different times, and even if it were to have happened at the same time, you could still have coalitions that were more developed and were further ahead along the continuum of planning to actual implementation and measurement of projects. So different levels, and I think that is appropriate because of it's appropriate and expected because of the different stages they might have already been before we came in and started to reinforce this, and also again, the different dynamics within the regions and the different partnerships. It's going to require some flexibility, and not just in structure, but also in timeline. And so as much as we can, we're trying to, because of the shared learning opportunity and trying to maintain the common focus on development, but it will never be 100% synced up.
Thanks, Chase. And now we really are going to plunge into some of the newer developments with regard to the ACH. And one of the key partners in the continuous improvement of the ACH is the Center for Community Health and Evaluation, who are on the call with us today to discuss their recent report on the first year of ACH development and how these regional coalitions are building the foundation for health improvements throughout the state. So we have with us Lauren Baba and Lisa Schaefer, who are going to give a presentation on the progress report / evaluation, with the opportunity afterwards for us and you to have ask questions as well. So we will turn it over to Lauren and to Lisa.
Thanks, Jonathan. This is Lisa, and I'm just going to talk really briefly about who we are, the Center for Community Health and Evaluation, and then give a little bit of an orientation to our evaluation and measurement framework. And then I'm going to pass it over to Lauren to talk about some highlights from our Year 1 evaluation report that just is pretty much finalized just now. We're really excited about it. So we're the Center for Community Health and Evaluation, or CCHE. And we're a relatively small evaluation team housed within the Group Health Research Institute in Seattle. And we have over 20 years of experience working with foundations and health systems, government agencies, and nonprofits in Washington, but also across the country, to help them evaluate their strategic initiatives and health improvement efforts. And over much of that time, we've had a portfolio of work that's evaluating multi-sector coalitions or collaborative health improvement work. So we have a bit of experience and expertise in this type of work. And we really try to take a practical and collaborative approach to evaluation. And so we're bringing that to the ACH evaluation as well. So our goal is to really partner with both HCA and the ACHs as well to collect useful data that we can then share back with them in real time to inform program improvement and strategy development. But of course, we also all want to know what difference the ACHs are making in terms of community health transformation. So the evaluation also includes an impact evaluation at the end. So this slide is an overview of our evaluation framework and sort of highlights our key questions for Year 1. Our contract started last May, I think, and so one of the first tasks was to evaluate a framework for the initiative overall. But in this last year, we're focusing mostly on the formal or official development of the ACHs, but as Chase says, acknowledging that often being built on existing partnerships, existing work at the local level. So we've engaged in several types of data collection activities to better understand the development of the ACHs and what this has looked like on the ground in the different regions. So we've done site visits and interviews. We did a web-based participant survey of all ACH participants across the state. We've observed various types of meetings at both in the local communities and also meetings where all of the ACHs are getting together and talking with each other. we've reviewed the designation applications that Chase mentioned, and really we're in this first year where we were focusing. Can you go back to that previous slide? Thank you. We're focusing on these questions on the left side of this slide, which is have the ACHs built the operational foundation for multi-sector regional collaboration? Are they participating in sort of the broader Healthier Washington activities that Chase kind of briefly talked about? And then what lessons are we learning that can help shape the direction of the ACHs going forward? So this is all housed in sort of a measurement framework, and part of our job is really thinking through how to really measure ACH progress, and in an effort to effectively tell the story of how ACHs are making an impact. And we also want to document the contribution of each ACH to progress related to a broader set of long-term regional health improvement metrics, and those goals have been identified by state partners. That this set of common measure set that's been developed by the state. So if we look at the next slide, we're taking this is a little bit in the weeds, but to just give you a sense, we're using a measurement framework that we call a chain of impact. So Chase kind of mentioned this, but the overall vision for ACHs is pretty ambitious. And the vision acknowledges that a lot of the goals for ACHs, they're not going to happen overnight. So we have this chain of impact where we look at shorter term, more intermediate term, and then link that to longer term outcome measures. So in the short term, which is now, like I said, we're really looking at ACH functioning. How well are ACHs working together and facilitating regional collaboration and collective action? And Lauren will talk a little bit more about what we're learning in there. But then, starting now, starting in this next year, we're also going to be looking at and measuring the impact of the individual ACH projects, as well as trying to better understand their participation in other Healthier Washington activities, like Chase mentioned, the Transformation Hub, behavioral health integration, that kind of thing. And then finally, our job is to sort of link that work to changes in regional health outcome measures, things like ED visits and hospital readmissions, or broader child and adolescent health outcomes, things like that. Again, we're at the beginning of the initiative, so we're focused on short-term outcomes, like those mentioned that are in the left-hand column under the orange arrow. And so that's mainly what we talked about in our first year evaluation report. And I'm going to hand it over to Lauren to talk really in a big picture way about what we're seeing so far in the evaluation.
Thanks, Lisa. So the next few slides are going to do a high-level summary of what we found in the first year. And I think that our findings echo a lot of what Chase and Jonathan spoke about earlier. So I think that overall we would summarize the first year as a success. As Jonathan and Chase mentioned, all 9 of the regions were formally designated as ACHs by the Healthcare Authority. And this included engaging a wide range of regional stakeholders, developing formal governance structures to guide their collaboration, and taking steps forward in health improvement planning for their regions and developing ideas for projects, as well as starting the conversation about sustainability and how they'll carry their work forward in the years to come. Getting into more specifics about their development, the first half that we'll look at is on government structure and backbone support. So for governance, I think that a theme here has been that although they have all reached the the bar of designation, they've taken very different approaches, and so governance structures have varied. In terms of their regional decision-making bodies, they range in size. Some of them have boards or councils of 15 members. Several of them have somewhere in the 25 to 30 range, and some of the ACHs also have much larger decision-making groups of about 44 participants. In addition to these central governing bodies, they also, some of them have decided to develop steering committees or support teams that are a subset of their decision-making groups to help by submitting recommendations or managing administrative support for the board or council in between meetings. And then also, in addition to that governance and decision-making group, some of the ACHs have decided to create additional stakeholder groups where people can provide ideas and input and recommendations for the decision makers to consider on behalf of the entire region. Some of the ACHs have decided to have those stakeholder groups be region-wide, and others have decided to have individual county groups. And the idea of all of those is to have a relatively large group of stakeholders in the room, about 30 to 40 people, meeting regularly to talk about the ACH's development and their ideas of what they see as priorities and how to move forward as a unified region. For the backbone organizations, we've seen that there are 3 different types of organizations that are providing the sort of logistical and administrative support to the entire ACH through its development. There are 4 ACHs that right now have local public health agencies serving as that function. A number of these agencies were kind of a natural convener for the group and helped put together all of the stakeholders in the region, and also provide some support in terms of gathering data and analytics for regional priority setting. 3 of the ACHs have other community-based organizations serving as their backbones, and these are organizations that have a history of bringing stakeholders together in either a portion or the whole of their ACH region to work on community health as a group. And then finally, there are 2 ACHs that have nonprofit organizations that actually serve as a dual role for the ACHs. So they have staff that provide the backbone support, and they also have a nonprofit board of directors that serves as the decision-making group for the ACHs in those regions. And one thing that I think we've noted is that, you know, the ACHs are ambitious and complex, and so the backbone organizations' responsibilities are significant and growing, and so it's been great to see them coming together at meetings across the state to talk to each other about how to develop and move forward. On the other side of development, there's multi-sector representation and community engagement. And all of the ACHs are working towards a very broad multi-sector stakeholder representation in their ACHs at varying levels, the decision-making group and the county groups and regional stakeholder groups. And they've all defined sectors a little bit differently and have taken different approaches in how to incorporate sectors into their ACHs. So some of them stipulate in their bylaws which sectors need to have representatives on their decision-making groups or how many seats each sector will have, and others have focused on having counties have equal representation in addition to having multi-sector stakeholders at the table. So that's sort of some of the variation that we've seen, but they all have been working towards what Chase talked about in terms of the whole person health, that having sectors at the table that represent all aspects of people's health and well-being in the community and also in care. And then in terms of community engagement, they've also taken different approaches with that. A number of them have websites or newsletters where they provide information to the public on their activities and development and documents about what they've been doing. They also have different strategies for getting the public engaged in their activities, like having open stakeholder meetings where anyone can show up and participate, or having public comment periods during their board meetings. And And then also some of them also have consumer representatives as part of their decision-making group. So they'll have a seat or more set aside on their board or council that's to be filled by a member of the public who's a consumer of healthcare to give that community voice to the ACH. And looking towards, so that kind of sums up what all they've worked on and developed over the past year, and then we've already seen them starting to make progress towards the focus of year 2, which is identifying their regional health priorities and working on collaborating on regional projects. So in terms of priorities, we've seen the ACHs develop regional needs inventories and a list of regional assets, and they've been coming up with their own list of maybe 5, 6, or 7 priorities that will guide the ACHs moving forward. And some common priorities that we've seen across all of the ACHs would be access to care, behavioral health and health integration, care coordination, health equity, and then addressing the social determinants of health. In terms of projects, all of the ACHs are at different points in terms of selecting a project topic and aligning stakeholders to collaborate, but that will be a key piece of work for 2016. And this is really an opportunity for the ACHs to demonstrate their value to their regions by breaking down any silos between sectors and doing projects that really bring people together to work on those aspects of whole person care or whole person health that Chase mentioned earlier. And in sort of summary, I would say that our report has just been finalized and submitted, and it will be posted tomorrow on the Healthier Washington website. In addition, there's also a 4-page executive summary handout that will be made available that provides a little more context and depth and detail about each of the ACHs, but isn't as in-depth as the full report. So we hope that you find both of those documents helpful and informative.
So thank you very much, Lauren and Lisa, and I certainly would encourage all of those on the webinar to take a look at the evaluation. I would congratulate the Center for their work. I think it will prove to be a very useful document. A brief follow-up question before perhaps we can get some more later. But it's clear, and it touched on something you mentioned near the very end of your presentation. Clearly, the evaluation suggests that the ACHs are generally very aware of their need to demonstrate value. And in fact, themselves are getting antsy to move beyond the development stage to the, if you will, do something stage. How do they see themselves demonstrating value if there are people on the webinar, for instance, uncertain about their value? What should they be looking for in terms of where the ACHs plan to go next in terms of demonstrating value?
Yeah, thanks, Jonathan. That's a great question. I think that there are sort of the intangibles, things like breaking down silos between the sectors that haven't had a history of working before together, or building trust between different stakeholders that aren't familiar with each other's work to really see how they can collaborate together for the community's health. And also I think that it's interesting that there were some common themes in what the regional priorities were. Clearly, these are issues that a number of different sectors and stakeholders are grappling with, and so an opportunity for them to all problem solve together is a great opportunity for the ACHs to provide value, just a venue for those conversations to try to be more aligned and collaborative and efficient. Reducing redundancies across the sectors is a great opportunity for the ACHs to contribute to Healthier Washington and to their regions. And then finally, the projects that they are starting to identify and plan and implement later this year will give them the more tangible specifics, the action that you mentioned, where we'll be able to see in a measurable way how they are saving money for health systems or increasing efficiency and coordination across different stakeholders and improving population health measures. So I think that there's the relationships and kind of the regional identities is one form of the value, and then the others is going to be the measurable outcomes that our evaluation is looking at in terms of money saved and really bridges built between everyone.
Thank you. Thank you very much. Thanks again for the evaluation. Again, I would certainly encourage all of you on the webinar to get a copy and take a look at it. We're going to transition now to another new development or update, I guess I would say, and briefly discuss the envisioned role of the ACHs in the state's proposed 1115 Medicaid waiver. And we'll turn again to Chase and his team and ask very specifically what is the role currently proposed for the ACHs in the transformation waiver, and will they be prepared to take this on?
Yeah, the ACHs, we mentioned, beyond SIM under Healthier Washington, there's an opportunity there, and trying to create new partnerships or build on existing partnerships and focus on health in a new way. And that's really what the waiver reinforces. So it's hard to talk about the ACH role within the waiver without very briefly, just going over a few of the main components of the waiver. So, of course, it reinforces the triple aim of better health, better care, and lower cost. You can see that represented in these specific goals. Just really briefly, reducing avoidable use of intensive services and settings, improving population health, accelerating the transition to value-based payment, and controlling or reducing the Medicaid per capita cost growth. So that's just high-level goals of the waiver. So when we talk about the ACHs, we're really talking most specifically about Initiative 1. So the waiver has 3 initiatives focused on those goals. The first one, transformation through accountable communities of health. So this is where the state proposes that we need a partnership like the ACH with the multi-sector representation, with the focus on regional strategies that align with state priorities, that align with these goals that we've outlined through the Medicaid transformation application. We really need that local partnership to make this happen. And it's a new way of investing, and that's what the waiver provides, is some flexibility in how we invest and test the ways to improve health and reduce cost and improve care. So the ACHs, the proposal would specifically have the ACHs coordinating regional applications. So of a list of projects or specific strategies or specific objectives, the ACHs coordinate the applications of how that region would specifically take on those projects. The ACH, being the lead, would contract with services and service providers as appropriate to implement those projects. And really this aligns with the intent of the ACH, regardless of the funding that comes through the waiver or other opportunities within SIM and beyond. That this is, as Lauren said, this is an opportunity to focus on ways to align where we haven't before, to coordinate across sectors where we haven't before, or across communities. And so just new opportunities here, and that's why it makes sense. We have the health system partners represented around the Accountable Community of Health table. We have the community partners represented. And so when we talk about new ways of partnering, new ways of investing, and different projects and strategies that are local, this is the exact reason why the ACHs are part of the discussion and plan.
So with regard to the waiver, one of the terms that is frequently heard, or has been frequently heard recently in terms of an update, is that the state has learned that it won't have the benefit of what it labeled a year zero. For those who've heard of it, and those perhaps even on the webinar who haven't, a little explanation about the absence, what that year zero referred for, what its absent will mean, and how the state will be adjusting since we've learned that it's not something we'll be able to take advantage of.
Yeah, So the waiver timeline is a 5-year demonstration, and when we talk about year 0, it's to say that before that clock starts on the 5-year demonstration, there might be some time for capacity building and planning that occurs before the clock starts. And so in some ways it's that free time before we officially are in demonstration. So without year 0, it means that as soon as the waiver application would be approved, clock starts and we have a 5-year demonstration. So what's important though is that the capacity build is still required. There are still new functions that need to be developed within the regions, within the ACHs. There's still planning that needs to be part of the process, and there's still resourcing that we expect to support that. So that doesn't go away. Maybe it accelerates. Maybe it forces us to just be thinking about how to be really strategic without that additional time. But we still know the capacity the build is necessary, the resourcing is necessary, planning is necessary. Just don't have the additional flexibility.
So in essence, which is the absence of the year 0 will actually mean at the back end of the demonstration is where, if you will, we will lose time, because there's things still that will need to be accomplished that the state intends to accomplish in terms of ramping up and preparation at the front end that will not be lost because of this determination at the federal level. One other question about a waiver before we open up for general questions from those on the webinar. How much discretion will each ACH have, assuming the waiver is approved, in deciding what projects it will pursue? Is there a way for them to provide input? Most people may know on the call there was about 180 projects, ideas submitted from around the state that will now be narrowed down by the Healthcare Authority and CMS. I mean, is there a way for ACHs or ACH participants to provide input as those projects, that project list is down?
Yeah, so I mean, I think you mentioned the first step in collecting that feedback was through the project proposal submission, which was really a way to capture different ideas. It's not to say that each of those proposals will be scored and specifically implemented or not implemented, but there could be components of many different applications of those proposals, I should say, not applications, but many different components that will be addressed. So that's the first step, and so we really appreciate all of the work and energy that went into that, not just ACHs, but other partners. Now there are those proposals and ideas are online for public comment, and we're receiving feedback from ACHs, and we welcome feedback from other partners as well on either specific ideas that resonate with efforts that are underway or envisioned with regional priorities. And so there's the public comment opportunity, and then of course we're looking to ACHs around planning and priority development and constantly having that conversation. And so I think that's another way that it informs the process. But ultimately, as you can see here, there's negotiations with CMS. We don't have a menu. We don't even know the number of projects. We don't know specifically what projects might apply consistently across ACHs and what projects might be more of a menu where ACHs select from that list. So there's still a lot to be worked out, and so that's why feedback is useful. And you can again go online and see those ideas and provide additional feedback and comments on that. So as far as the ACH discretion, I think that's still just to be negotiated. I think that's the intent. There's some level of discretion, but the degree really depends on how many projects are on a menu and what standard process might we.
And it sounds like it consistent with the notion of balancing the ACHs as a statewide initiative, but with the ability to address unique local issues and to build in that flexibility and that balance. So now, and thanks to the presenters, thank you to Chase. We've got time for questions from our webinar audience. If you want to use the chat function, is that?
Question function.
The question function to provide us with questions. We've got some to start with here, but would certainly encourage any of you on the webinar to use the question function, submit your questions, and again, either ones that we can answer here today or can note for being answered either in the FAQ or on a future webinar. So with that, do we have some questions?
Yeah, so one of the first questions is, are any of the accountable communities of health or involved stakeholders and partners applying for the recently released CMS Accountable Health Communities grants? So lots of confusing terminologies, but are any of the ACH's involved stakeholders or partners applying for the CMS Accountable Health Community grants?
Yeah, so the Accountable Health Communities grant opportunity, it sounds very much like our Accountable Communities of Health initiative. There is some alignment there, but the AHC opportunity is really about clinical community linkages, and there are specific tracks and work within those tracks that you can apply for, just for those who haven't heard. So you can look up the Accountable Health Communities grant opportunity if you want to learn more. So we know that ACHs have been coordinating some discussions around who's interested in applying, what's the lift here with this AHC opportunity, what's the funding to support the lift. So we do have, I think, a couple of ACHs themselves that are interested in applying, that plan to apply, and then partners within ACHs that are interested in applying. So where we're at because there's clearly a partnership here with the state Medicaid agency, and you can see that called out within the funding opportunity announcement. So the HCA, as the state Medicaid agency, would need to sign on and support. We really do want to see the coordination with our regional ACHs. So it's not to say that every ACH will apply or should apply, but that when partners do want to apply, we are encouraging coordination with the ACHs on that opportunity. We think there's clearly a connection here, and something we should explore more. We're going to be sending guidance also, and that's going to go out today, I believe, on just timeline and expectations around how to notify the healthcare authority of interest, how to work with ACHs on your interest, and maybe initial timeline around drafting the application and how we can get involved in that process from the support role that the state Medicaid agency plays. So that should go out today. If you don't see it, check our website. We'll try to link to that there. You can email us. Our contact info is going to be up on the screen here in a minute. But that's a good question. There's just a lot that we could discuss on there, so maybe it's a good follow-up or something you can email us about.
So another question here is, I've attended several ACH meetings around the state, and some refer to their partners at the table as members, and some refer to them as participants. What is the terminology? What do they mean? What should we be referring to those partners as?
You know, one of the things, and I think this is a very good question, that we all are trying to get more consistent with. The ACHs are clearly not intended to be exclusive, but in fact are created to be inclusive. I think early on the reference was to members, but we're trying more frequently to talk about participants, so that it's made clear that this is an entity within a region that is open to really anyone with an interest in the health and well-being of that region. Now, that being said, you may hear reference to members, and I would suggest most likely that would be reference to members of the governing entity that ACH has created. One thing I think you'll need to be clear on is that there are multiple opportunities, and will continue to be multiple opportunities, to engage with ACHs in a meaningful way short of being on the governing board. So I certainly would look to others around the table here, but my sense is that there is an effort to talk more frequently about participants, to not suggest that the ACHs are in any way exclusive. But if you hear reference to members, either it is a mistaken reference to participants, and that's what they meant, or in fact they're talking about the members of the governing board, which may be a finite group.
Yeah, that makes complete sense, Jonathan. And you know, the participants and partners within the ACH should be very comprehensive, and that makes sense, especially considering these are regional partnerships, and you have many communities represented, and many organizations represented within the region. Yeah, and when we hear members, it's usually or directors, board of directors. It's around the decision making. There's a decision making process, and there's a group that ultimately makes those decisions using the feedback and the overall engagement. And that's when we hear members or board of directors, that would be a more limited reference.
I think the one thing I would say that I've heard from some individual ACHs, they really are, at this point, it gets back to what we've discussed a couple of times about demonstrating value as they move from organizing to implementing or organizing to action. What they really are needing and looking for in the communities is folks to participate in their projects. And so I would, again, encourage anyone, either if they're already engaged or thinking of being engaged, that is an ideal opportunity, again, not necessarily on the governing board, but to play a very meaningful role in your ACH, which is to ask about the projects that they have either embarked on or are about to embark on, and the role that you or your organization might play in those projects, because I think that they recognize, as do others, that really will be key in demonstrating the value they play in the state.
And I would say, just to add one more thing, on the Healthier Washington Accountable Communities of Health website, there is a link on the right-hand side, about the middle of the page, that says Contact Your Local Accountable Community of Health. And that's just a one-pager, so if you're a statewide initiative or you're in a specific region or county or community looking to get involved, that's the contact information for kind of those local key staff and leaders of the ACH. And that being said, if you feel more comfortable reaching out directly through us on how you should be engaged, our website will be up here at the end of the slideshow, and we are happy to bridge those connections and set up those partnerships as well.
Great, and we have to close out here at 3 p.m. To do so, I just want to remind everybody of March 17th, same time, 2 p.m. is the next webinar. So again, we want to address questions you have between now and then, and we have other questions already on the table, of course, that we'll be addressing, and let us know what worked for you with this call and what didn't work. There will be an announcement, a reminder of that webinar going out through our feedback network channel. Should be the same process of how you were notified this time. You can share that registration link with others, and then again, this is also about the ongoing development of our FAQ. So likely you'll see updates to the FAQ reflecting some of the discussion today, or